Okay. Hello, everyone. Thank you all for joining us today and welcome to our first ever Migraine Strong meetup. I'm Eileen Zollinger, and you might recognize me from the Migraine Strong Facebook group. We had originally planned to have this meetup in person back in March, and then we rescheduled it to June, but the pandemic had different ideas. We had to adjust our expectations and get a little creative, and here we are, just like the rest of the world, finding our way on Zoom. We are pleased that Huggaroo is generously sponsoring a giveaway for this meetup. They're donating one of their wonderful microwavable neck wraps and an eye mask. The whole Migraine Strong team has these, and we just love them. Huggaroo is such a great company that stands behind their products, and we always enjoy working with them. They're also offering a 10% off to the Migraine Strong community with the code Migraine Strong through Monday, November 9th at midnight. The winner of this giveaway will be announced later in the Migraine Strong Facebook group today. For a little bit of housekeeping, just keep your microphones muted so that everyone can hear the presentation clearly. Also, if you have any questions, please feel free to drop them in the chat, and we'll try to get to all of them after the presentation today. We also have some questions that you guys had left in the comments in our Facebook post, and we'll get to those as well. Through all of our delays and the schedule adjustments we had encountered with this meetup, Dr. Kevin Weber from the Ohio State University Wexner Medical Center has stuck with us and rolled with the changes. He is a neurologist and board-certified headache specialist who specializes in treating patients with sports concussions and migraine. He's also one of us, as he has migraine himself. He has very generously offered his time to us today to talk about the new migraine medications that have recently become available for migraine. He was recommended as a speaker from one of our Migraine Strong community members. We are very grateful for the introduction and his willingness to speak to us today. Dr. Weber, thank you for joining us. Could you give us a little bit of a background about yourself before you start your presentation?
Sure. So I am almost a lifetime Buckeye. I've lived in Ohio my entire life, but I'm from Toledo area originally, grew up there, went to Ohio State for most of my education, my undergraduate med school and residency in neurology, and then I went away to Cleveland Clinic for a year to do my fellowship, and then came back to Ohio State. We didn't really have a headache specialist at Ohio State until I arrived. We had Dr. Pakalnis, who was mostly at Children's. Now she's more at Ohio State with me, but she kind of splits time between the two places. But we didn't really have a full-time headache specialist at Ohio State before me. I'm pleased to share that we're growing. We have myself, we have Dr. Pakalnis, who's there part-time. We have another part-time member of our headache division, Dr. Robinson. We have a couple of nurse practitioners, Kathleen Moore and Alexa Murray. And we have 2 headache fellows this year. We're actively trying to recruit them to stay. So we're growing, and we have a couple fellows lined up for the next 2 years too. So those are beneficial in the sense that, of course, it improves access to our center because fellows see patients too, and it also, usually you end up keeping a couple of them. A lot of them end up staying on as faculty, which is always a great thing. In the Columbus area, other than at Ohio State, we have a headache specialist, Dr. Taylor, who's at orthoneuro and private practice, and then we have a couple, Dr. Awadala and then Dr. Pakalnis, who are at Children's, and they have a couple nurse practitioners there too. But it's still in the Columbus area somewhat of a need. Ohio as a state is actually pretty well covered compared to some other states. One of our fellows is from out west. He's from North Dakota, and he's looking to go back out there after he's done with his fellowship, and they don't have any in North Dakota. They don't have any in Montana, which is another state that he's looking at. So, there's some states who don't have any or very few. So it's a very underserved population. Migraine is extremely prevalent in society. Something approximately a third of women and about half that, 15% of men, have a migraine at some point in their life. So it's a super common problem. Chronic migraine, which is a migraine more than 15 days a month, or I'm sorry, headache more than 15 days a month, with half of those being migraine, is about 2% of the world's population, which you can imagine is, 2% of the world's population. It doesn't sound like that much, but with 7 or 8 billion people, you're talking tens of millions of people have it. So it's a really common problem, very underserved population, and we're doing our best to recruit more and see as many patients as we can. The wait to get in to see me at one point was approximating a year and a half, but now it's much better. With adding people, it's down to a few months, and we hope to get it even better than that, where it would be, a month or two, I think would be a good goal. So we're hoping to hire more faculty as we can. Today, I wanted to give you guys a brief update on, well, one, how to find a headache specialist if you're not from the Columbus area, and then two, a brief overview of some of the new treatments. I don't want to take too much time lecturing, so I have time for the questions, because I got a bunch beforehand. So I'll get started. I'm going to try to share my screen here. Oh, it says like the share screen is disabled. Let's see if.
I think I have to give you permission, so let me, whoops.
Well, I'll keep talking while you do that.
Where is that?
There's a couple different ways to find a headache specialist. Probably the easiest way is at the American Migraine Foundation's website, which is americanmigrainefoundation.org.
Okay, I think you can share now.
They have a kind of an interactive Google Maps type thing where you type in your zip code and they find people who specialize in headache near you. That one is, I think, a little bit more comprehensive. But you also have some people on there who may not be board certified in headache, but they just specialize in headache. There is a board certified list if you go to the UCNS website, which is at ucns.org, and that's the accrediting body that does a number of the neurology fellowships. That they do the neurology boards for a number of the different fellowships.
You should be able to share now.
Looks like I can. Good. Okay. So let me show you on the screen here. So this is the ucns.org. If you go to their main website and click on Diplomat Directory. Diplomat is just a fancy word for the people who are board certified. And then you click on headache medicine. You can type in a name if you're looking for a name, or you can look for a state. So for Ohio, we have a number of people throughout the state who are board certified, and it says when they were certified. And so this is a pretty good list. If you find someone on this list, that means they're taken the headache boards and passed them, and are certified in headache medicine. And then I'll show you the American Migraine Foundation website. If you go there, you can click on Find a Doctor. And again, as I was saying, there's an interactive map here, and you can type in your zip code. So I'll type in mine here, and you can see that on the map, you have Dr. Taylor, who's nearby within 10 miles. I'm sure on this list somewhere. Yeah, I'm on the list. My address is on here, is at the main campus, but I have a number of satellite locations around town. But you can see these are some of the people who are, who enjoy seeing headache patients. So let me get into my slides here real quick. I'll start with just some things. This is from my grand rounds that I gave a little bit earlier this year, but not much has changed since then. So I'll start just talking about some of the new treatments. So first I'll talk about rescue treatments, new rescue treatments for migraine, and then I'll talk about new preventative treatments briefly. Rescue treatments we consider in migraine are ones that you use when you have a migraine, not necessarily every day. Just to use when you get one. Nerivio is a band that you wear on your arm, and it gives, it's called remote electrical stimulation. Essentially, it's a form of neuromodulation. A simple way of simplifying it is that it overwhelms your pain system to the sense that it distracts the headache, kind of resets the pain system, which is located in your brainstem.
You have that slide up
acupuncture works
now?
this way too. I'm sorry?
I'm sorry, Dr. Robert, do you have that slide up now? Because we're still seeing the American Migraine Foundation.
Oh, yeah. I don't know. Let me see if I can figure it out. I don't know why. Let me see if I can figure this out. Screen sharing. Can you see it now?
Yep, there it is. Perfect.
Okay, let me go back to the, still see it?
Yep.
Okay, good. All right, so Nerivio is a band that you wear on your arm. Again, it provides neuromodulation. Essentially, it's overwhelming the pain system in your migraine generator, which is in your brainstem, and essentially resets your pain system in your brain. Other things that use this, there's some, acupuncture is probably the most famous, but there's other types of neurostimulators that we're not going to get into too much today because those don't have robust evidence yet in migraine, but that we do use sometimes with some refractory patients. But Nerivio is approved by the FDA for the rescue treatment of migraine. As you can see, this nice young lady here wearing it on her arm, looking at her phone like we all do with her wonderful dog, resting on her, trying to comfort her having a migraine. This treatment is a little bit expensive, $99 per device, which gives you 12 treatments, so it's about $8-ish per treatment. The nice thing about it is there's no medical contraindications, serious adverse events, or bad side effects. Unfortunately, these types of devices are not covered by insurance. Insurances, for whatever reason, tend to not like devices, medical devices, and it's a constant battle. There's non-invasive vagus nerve stimulation. This is also approved for cluster headaches. Essentially, you're stimulating your vagus nerve, and again, it's a similar neuromodulation mechanism. It did fail to meet its primary endpoint versus a sham treatment on pain freedom at 2 hours, but it met some other secondary endpoints. And I'm sorry about my dogs in the background. If you guys hear them, they do like to bark at anything that walks down the street. The non-invasive vagus nerve stimulation is, again, it met some of its secondary endpoints, but did not meet its primary endpoint in its trial. It's also called gammaCore. Some advantages of it are it's non-pharmacologic, non-invasive. Disadvantages are it has very poor insurance coverage, it's expensive. A lot of times people have to pay out of pocket for it. There are some contraindications to typically people with heart problems, if they have any problems with their carotid artery, and if they have any metallic objects or devices in their head or neck. There haven't been any sham controlled studies for prevention yet of migraine. This is just for the rescue. It has been studied pretty extensively in cluster headache, which is outside of the scope of our talk today, but it's sometimes you may hear it used in that condition as well. Ditans are, for the moment, just Reyvow, which is lasmiditan. This is similar to the triptans that you're used to hearing about, like rizatriptan, sumatriptan, etc. Except for this one does not constrict the blood vessels. It goes after a slightly different target. Very effective. There can be some significant dizziness with it. And unfortunately, the biggest problem with this, and which is why I don't prescribe it quite as much as the Gepants, which we'll get to in a second, is that it comes with an 8-hour driving restriction after taking it. And that's A lot of the new migraine rescue treatments now are tested. This is a requirement from the FDA and the DEA to make sure that to do a driving test to make sure people are safe to drive afterwards. I wonder if some of the triptans would have this restriction if this had been required when they were approved. But anyway, there is an 8-hour driving restriction after taking it. So this is challenging to give to someone who works outside of the home. There are no contraindications with this medication, which is nice for our patients who have had a stroke before a heart attack, because people cannot have triptans who have had a stroke or heart attack in the past, or peripheral vascular disease. Gepants are the new, also out. They are CGRP antagonists, and those are out right now as rescue treatments. They're also being studied for prophylaxis as well, daily prophylaxis. They're oral. There's Reyvow and Ubrogepant, Ubrelvy, and Nurtec. Most of you, I'm sure, have probably heard about these, seen commercials as Serena Williams. Every patient asked me about the Serena Williams drug, so that was a marketing success on their point. And I guess Nurtec got Khloe Kardashian. I haven't had as many people ask about her, but I don't think she's as popular as Serena Williams. So Serena Williams was definitely a good get for them, for Ubrelvy. These are very effective. You'll see that they're pain freedom at 2 hours, and a lot of these, that's usually the main primary endpoint for these medications like triptans, but they also usually look at pain relief, which means, you feel better, but not all the headache isn't all the way gone. So these were all statistically significant versus placebo. These don't cause vasoconstriction either, which is nice. So that means you can give them to people who've had strokes or heart attacks before. Ubrelvy or Ubrogepant, you get 10 pills per month. It's $10 a month with your copay card, so it ends up being about $1 per pill. There are some medication interactions, which I'm not going to get too much into, but we just have to be aware of those as those medication, with those medications, you just have to make sure your doctor's aware of those. Nurtec, again, had similar, very good data. This one dissolves under the tongue. It does seem to work a little bit faster than Ubrelvy, although with Ubrelvy, you can repeat it after 2 hours. With Nurtec, it's just one dose. Now, we'll talk about, I'm going to scroll through this quickly because I don't want to take too much time talking, but we'll talk about some of the new preventative treatments. There's single pulse transcranial magnetic stimulation, transcutaneous supraorbital neurostimulation, and the ones that everybody knows about, the calcitonin gene-related peptides. There are some new future targets on the horizon or that are being studied, like PACAP ligands, orexin, a few different other opioid receptors that are being studied as targets for future migraine prevention treatments. And then there's percutaneous mastoid electrical stimulation, which is a stimulation electrode, as you can see, placed right behind the ear. That's currently under study. Doesn't have a sham study yet, but there's been some promising results with that so far. So with prevention, there's auricular. Another one is auricular non-invasive vagal nerve stimulation. And again, there's not a sham study with this one yet, but it did show some initial benefit. Interestingly, the placement is kind of in a similar place as the daith piercing, which I'm sure a lot of you have heard about. Some of you may even have it. So the thought is, again, it's this neuromodulation process of your overwhelming your pain system and causing it to reset. In the migraine world and headache world, specialist world, a lot of people are very skeptical over the daith piercings. That it's just placebo. I have read the proposed mechanism for that, and I think it's reasonable. It's kind of similar to this. So I don't immediately blow it off. Honestly, I think it looks kind of cool. So, I tell people the worst case scenario is you have a cool piercing. I guess that's not true. The worst case scenario is that it gets infected, but I mean, you can get that with any piercing. A lot of people have their ears pierced. So, you know, the daith piercing, I have seen it help some patients. Other patients said it didn't do anything. We don't have a lot of randomized controlled trials on it. We don't have any. So it's something I don't discourage my patients from, but I tell them it's possible it might not work. And this auricular non-invasive vagal nerve stimulation. This is also used sometimes with some of the GI conditions, which is again out of the scope of this talk today. But and I've actually had some patients who have gotten this for GI conditions, and it helped their migraines as well, which I thought was interesting. There's caloric vestibular stimulation. I'm not going to get into this too much, but essentially, if any of you, especially those of you with vestibular migraine, have ever had vestibular testing before, you know what calorics are. It's injecting some air into your ears to see which way your eyes move. This is stimulating your vestibular system. And again, this is a form of neuromodulation that's under study for migraine. It has some promising early evidence. Brain TMS is the transcranial magnetic stimulation. This is again used in other conditions, like in depression and other similar conditions. But it's been studied in migraine and has been shown to be beneficial. It's approved for the acute and prophylactic treatment of migraine by the FDA. There's still a little bit of lack of data on this. A lot of insurances don't cover, and there's a pretty decent upfront expense from out of pocket if you do want to try it. A few $100s up front. I have found that this medication tends to be better in patients with migraine with aura than those without aura, and that's just my personal experience, and the mechanism that this works in makes sense. Essentially, it's like a magnetic pulse delivered to your brain that is supposed to stop the mechanism of migraine with aura, which is this cortical spreading depression. Without getting too sciencey today, essentially I describe an aura as a chemical wave that goes across your brain, and this magnetic pulse is proposed to stop that. So I do, in a few patients, have tried this device. It doesn't always work. It can help some patients though. And that's what it looks like. It's a device that you put behind your head. The nice thing about this one is, again, anyone can use it. There's not a lot of contraindications unless you have some sort of metal in your head. Cefaly is much more widely known. That's approved by the FDA for migraine prevention and the acute treatment of migraine. It's not covered by most insurances. The military insurances cover this one, which is interesting. So if you're in the VA or if you have TRICARE, they'll cover this, but most of the other commercial insurances and Medicaid, Medicare do not cover this. And it is a decent out-of-pocket expense. It's around $500 for the combined device, and then you have to replace the electrodes occasionally. Cool-looking thing. It used to look like a tiara, and I think they thought they were scaring away their male patients, so they just made it a much more gender-neutral looking sticker device that you put on your forehead. I've tried it out a few times at our conferences, and I thought that it felt pretty good. I thought it's just like it's like a tingling on your forehead. Essentially, it's going after targeting your supraorbital nerve. Again, a form of neuromodulation to reset your pain system. The evidence behind this is a little bit weak. They did meet their endpoint of 50% responder rate, which means the percentage of people who responded to the treatment, but there wasn't a significant difference in number of headache days per month. And that's what the sticker looks like. Again, it's a very non-invasive, something that anyone can have, and very few side effects. So that's something that's appealing to a lot of people who don't like pharmacologic treatment. And finally, here are the CGRPs we'll get to. A lot of you have heard of these. There are 4 that have been studied. This is a little bit out of date, and this slide's a little bit out of date in the sense that eptinezumab is available now. That's Vyepti. There's 4 of them. 3 are subcutaneous injections, and then the last one, Vyepti, is IV treatment every 3 months. And that's done at our infusion center at Ohio State. We have been able to get it arranged at some other infusion centers. So it's something that's pretty widely available now if your headache specialist knows how to get a hold of it. The other 3, that are Aimovig, Ajovy, and Emgality, are very widely available. You know, even some PCPs prescribe these. Certainly a lot of neurologists do, and then headache specialists do. We do all the time. They have pretty good evidence, very few side effects, although we have, since the clinical trials, found some more side effects in the real world data than we have than we did in the trials. In the trials, essentially, the only side effects found were injection site reactions, some upper respiratory infections, and then in the case of Aimovig, constipation. And Aimovig, which is slightly different than the other 3, Aimovig is targeting the CGRP receptor, whereas the other 3 are targeting the actual protein itself. Aimovig has had some issues with really bad constipation. I mean, not just constipation, but like constipation requiring surgical intervention, and I have had that happen to a patient. There's also been some reports of hypertension with Aimovig, but not so much with the other 3. CGRP does cause blood vessel dilation, so you would, you know, that's always been the concern with CGRP, you know, these medications, is that if they're blocking your blood vessels from dilating, does that cause them to constrict, and are they a risk for people who have heart or vascular problems? The answer to that so far seems to be no. Other than that, with the Aimovig, like I said, there's been some hypertension, but there has not been reports or evidence in either in vitro or in vivo data that there's a cardiac or vascular risk with these medications. Some advantages of them are that they don't have a lot of side effects as compared to the oral treatments. They don't interact with other medications. And then there's a lot of competition, which is good for patients. Most of these are very accessible for patients. Vyepti is a little harder to get. Usually they want you to fail one of the other, at least 1 or 2 of the other CGRP treatments first, but these medications are fairly easy to be accessible for most of my patients, because usually by the time they get to me, they've failed other treatments. Disadvantages, you know, cost, they are expensive, but like I said, they're getting more and more accessible. Even Medicaid, Medicare, these are available now. There's still some uncertainty with the cardiac patients. Like I said, Aimovig was actually studied in some stable angina patients. Like they did a stress test with them, a cardiac stress test, and there was not any difference between the Aimovig patients and the placebo. So I feel pretty comfortable giving these to cardiac patients. Pregnancy, there's still not a lot of data on these medications in pregnancy, and I don't typically give them to women who are actively trying to get pregnant. As far as, and there's also, you know, some patients who have been on Botox therapy who, you know, are also interested in these, and it's been somewhat challenging to get them both covered. Without getting too much into the nitty gritty of it, it seems like the best success seems to be with the people who have a separate pharmacological component to their insurance, like they have Express Scripts or, you know, the CVS mail order or some sort of separate prescription drug insurance, and then they have their medical insurance, because Botox is usually run through the medical part, and the CGRP treatments are run through the pharmacological part. So sometimes, you know, they don't seem to care that you're on both, but I will say that it certainly is, it is challenging for most people to get both covered. I think that's about it. I don't want to spend too much more time on the new, talking about lecturing to you guys. So I want to take some of these questions. There were a few that were given in advance.
We have one come up in the chat. You go.
I have a few that I got in advance, and I can start with those.
Okay.
And then I'll get the ones in the chat too. Looks like there's a few in the chat that I'll get to. So if people want to type their questions in the chat, they can.
Okay, that sounds great.
So the first one is, what has been your clinical experience with migraine patient efficacy across mAbs and Gepants? There's not really any, in the headache world, there's not really any miracle drug. Everybody's different, everybody's unique. There's a lot of trial and error in my field. I have found that they are very effective, the monoclonal antibodies for prevention and the Gepants. I've found some patients tell me they don't do anything. Some patients tell me they work really well and nothing's ever worked before, and oh my God, these are a miracle. So it's that way with every new treatment that comes out. And the important thing is that there are new treatments coming out, and it's all the time. For decades in the migraine world, we didn't have a whole lot of additional treatments. There were the triptans that came out in the 90s or late 80s, early 90s. And since then, we haven't really had any new migraine treatments other than, I guess, Botox, but until these CGRP treatments came out. So it's an exciting time because there's definitely a percentage of patients who respond to these who didn't respond to any other treatment before. As far as, have you seen people have success with one or the other or both? I haven't found that any of them are far above the others. In respect to the antibodies, usually some people come in with a preference for one of them. Some people only one or two is covered on their formulary and we go with that one, but they all work. Their data is all pretty similar amongst all of them. Vyepti may have slightly better data for chronic migraine, but it's not, extraordinarily so. And then as far as the Gepants go, I have not found a significant difference between the two so far on the Ubrelvy versus Nurtec front as to which one's more effective. As far as my thoughts on the forthcoming, and let me go back to that one real quick. And some people ask, well, what about Botox versus the CGRP antibodies for prevention? I think Botox works better for the patients who have a significant cervicogenic component to their migraines. So if they've had a lot of neck tightness, stiffness, they've had a lot of neck problems before, those people, in my experience, tend to respond a little bit better to the Botox. We put the injections there. But, I have seen some of those people respond really well to the mAbs, the monoclonal antibodies as well. So it's certainly not impossible. We try, usually with those patients though, I start with Botox and then go to the antibodies after that if the Botox does not work. What are your thoughts on the forthcoming PACAP inhibitors? Those, I did mention those briefly earlier. Those are still very early in the study. So we don't have any clinical trial data on those yet as far as efficacy. So it's kind of a wait and see. It is a cool thing that we have, we're still studying some new types of treatments coming out that we have some other things to offer in the future. I will say also there is at least one more CGRP antagonist on the horizon. And that's similar to Nurtec and Ubrelvy. The company that makes Nurtec, which is Biohaven, is also studying a nasal spray form of it, which I think would be beneficial to a lot of our patients, especially ones who tend to vomit up their oral treatments. and certainly also to some of our cluster headache patients, which is again outside the scope of this talk, but typically cluster headache patients, need those come on very, very fast and are more severe than migraines, and they need quick, faster treatment. Have I seen any success with vestibular migraine patients using Vyepti? The Vyepti is pretty early on of us using it. We started using it, I think, in July and August, because it took a little while for it to get approved by our insurance or by our infusion center. So that one, I have seen some initial success with it, but also with Vyepti, and I was telling some of my other colleagues this the other day, you're getting some of the most refractory patients who get Vyepti, because usually they have to even fail a couple of the other injectables like Aimovig and Ajovy. So you're getting some of the most refractory people. So anytime that you try a new treatment, you can't, and the only people you're using it on are people who are really refractory, you can't make a whole lot of inferences about how well it works. Because for some people, some of those people, I don't ever tell anybody that nothing is ever going to work, but you have to, just put it in the frame of reference to the population that you're using it on. And I have seen it work even on some of the really refractory people. So like I said earlier, there are some treatments that, it's a matter of just keep trying things, because eventually, with a lot of patients, you find something that works. But I don't have a whole lot of, it's too early to make any inferences on the success with vestibular migraine patients using it versus, because we haven't used it that long yet. Do you have any concerns or clinical observations of other bodily effects from CGRP suppression? So that, again, I think goes back to the hypertension with Aimovig. I would be careful with that medication with patients who have constipation already or who have uncontrolled hypertension already. And I would be cautious with the other CGRPs as well with those patients, especially with the constipation, because I have seen constipation with the other treatments as well. So, I don't have a whole lot of long-term concerns with CGRP suppression. These medications have been out for a couple of years now, and then they were studied in clinical trials for several years before that. So we have, at this point, almost a decade of safety data on these medications. And we haven't found any long-term problems yet. I'm not saying it's impossible, but it seems each day that goes by, it seems less and less likely that there are long-term problems with these medications. When it comes to preventatives, what are some of the proven CGRP medications that can assist with vestibular migraine and chronic migraine symptoms? The CGRPs have not been studied very well in vestibular migraine yet, just because vestibular migraine itself is kind of a controversial definition. Certain groups have different definitions of it. The ICHD-3, which is our International Criteria of Headache Disorders, basically defines it as, half the time that you're dizzy, you have a migraine with it, which I think is a pretty fair definition of it. You wouldn't want to attribute someone's dizzy or vertigo symptoms to migraine if they have one migraine a month, but they're dizzy all the time. So, I consider vestibular migraine, I think saying that at least half of the dizziness has to be attributed to having a migraine with it makes sense. But that being said, it hasn't been, the CGRPs particularly haven't been studied in that condition. I do have, let me see if I can pull up my article here and share it with everybody. And I can send this out to the group too. There we go. So this is a really good article. and I can send this out to the group, but essentially it talks about vestibular migraine, the definitions, and then some of the treatments that have been studied. There haven't been a ton of really large trials in this condition, but there have been some preventative and rescue treatments studied. And I can send this out to the group if anybody wants a little bit more detail about it, but this is a really good article.
Yeah, that'd be great. We'd love that.
Let me go back to my questions. Oh, so we don't have a ton of evidence on the CGRPs and vestibular migraine yet. In my experience, it works. You know, I guess Dr. Oss, who's our disease specialist, from what he's told me, he said that he doesn't think that they work as well for vestibular migraine. I have not found that. I think they work about as well for those patients as they do the other migraine patients. But Dr. Oss also sees a lot more vestibular migraine than I do. We have a lot of overlap in our practice. I would like to know if we are seeing more side effects from the abortives, like Nurtec and Ubrelvy, now that they are widely available. If so, what are you seeing? I have not had really anyone complain about any side effects that I can think of with the Nurtec and the Ubrelvy. I have had with the Reyvow, there's been quite a bit of dizziness and tiredness with that one, but I've also had people tell me that it's very effective. It is really good at stopping the migraine. So if that's your goal and you have the ability to kind of, you know, lay down and relax and not do anything the rest of the day, then Reyvow might be a good choice for you. But with Reyvow, there's definitely significant dizziness and sedation with that one, and that's probably why they have the driving restriction. Are we seeing any itching and joint pain with any of the CGRP meds? No, I haven't seen that other than the injection site. I mean, there's been some injection site itching with a lot of the injectables with Aimovig, and especially Emgality that's galcanezumab seems to be the biggest culprit as far as injection site reaction goes. The interesting thing is that Emgality and Ajovy, which is fremonizumab, also come in a syringe. So if the auto-injector is causing you to have an injection site reaction, I have had some patients do much better with the syringe. The problem with the syringe, though, is it is a needle that you have to inject yourself or have someone inject for you, and some people have a problem with that. The auto-injectors are much easier to use, but also cause a little bit more injection site reaction. Are there any specific concerns or considerations of someone with chronic migraine begins to have visual aura after more than 20 years without? I don't want to get into too much medical advice here, but I will say in general that I have seen that patients can get auras after not having them for a really long time. And it particularly is common in women after menopause, where I will see women have either more auras or new auras, or they'll have auras without migraines after menopause. And it has to do with your hormones changing. Of course, migraines are very estrogen sensitive. They're more common in women, although men get them too, because it has a huge genetic component as well. But I will say that in itself, you know, someone having aura after not having it for a long time is not concerning, as long as there aren't other medical, you know, other things going on like neurologic symptoms. Do I have any insight in the emotional fallout from vestibular migraine? What are effective coping strategies? Certainly some people have what's called a postdrome after a migraine attack. And that's no different than vestibular migraine, where you can feel down in the dumps. Interestingly, and I haven't heard this described very much, but with me, I get almost the opposite. I get like euphoric, like I get a bunch of stuff done after the migraine's over. Like I'm like, it's almost like I've been, you know, taking some sort of like stimulant or something. I don't know. I feel like I'm almost like hypomanic when I have after I'm done with the migraine, and that's just me. But I notice it almost every time. But a lot of people, it's the opposite. They feel very fatigued, they feel down, depressed, and they kind of feel out of it for 1 or even 2 or 3 days after a migraine attack. Coping strategies, you know, there's certainly a huge mood component with migraine. And I certainly encourage my patients who have any sort of comorbid depression or anxiety to have a regular therapist. There's a lot of evidence in migraine for both cognitive behavioral therapy and mindfulness and relaxation. So if you have ever received training or therapy with those modalities, I would suggest that you use what you were given in those situations. But it certainly can be challenging because we don't have a great treatment. I don't have a medicine I can give you for the post-drome after a migraine. We have the triptans and the rescue treatments, and those are great for stopping the pain. That's what they're mainly for. But they're not as great for the post-drome symptoms. They're not as great even for the aura. They don't really, they mostly just help with the pain and not with any of the other symptoms. Well, I mean, they do with like the nausea and the photophobia and things, but not the extended symptoms afterwards and not with the aura. So it can be really challenging. And I think that if those are a consistent problem for you, making sure that you get therapy and get set up with some cognitive behavioral and mindfulness therapy, relaxation therapy is helpful. What are some things we can do during a vestibular migraine attack to help mitigate symptoms and for the post-drome after? I think we just kind of talked about that. Other things that you can do during a migraine attack, other than medication. Of course, some people find benefit from caffeine, although not all. Some people find benefit from, and again, sorry about the dogs, if you guys hear them. The UPS guys. So during a migraine attack, there's these ice packs that you can get online from Amazon, and they're called like migraine head packs or ice, but a lot of people find ice to be beneficial. Certainly hydration, if you can keep it down. If you have a nausea medicine, using that. Rest is really important. A lot of people use ice or heat. And then, of course, any of those strategies that we were just talking about, like the relaxation, mindfulness strategies. Can Botox help vestibular migraine sufferers who do not have pain? Botox is typically helpful more for people who have migrainous symptoms. So I'm not sure, that question is a little bit, I assume that means for people who have vestibular symptoms when they're not having a migraine, but by definition, again, we talked about this earlier, if you have migraine and vestibular symptoms and you have vestibular symptoms all the time, but you only have a migraine once a month, I don't think that's vestibular migraine. I mean, that's probably something else going on. But if you're having a migraine or head pain more than half the time that you have vestibular symptoms, then that would be considered vestibular migraine. And I would, the Botox should at least help with the pain aspect of things. The Botox may also be helpful if you have a cervical component of your vestibular symptoms. I would like to know what the best abortives are for vestibular migraine. What about timolol drops? So timolol is being studied as a rescue treatment in migraine. Timolol is actually approved as a preventative treatment for migraine, the oral timolol. Timolol drops are used for a number of different other eye conditions, and they've been studied in migraine, or they've been studied as a rescue for migraine, but we don't have any data on that yet. Let me bring up my article here again. Let's see here. Let me find it here real quick for us. Okay. There it is. Okay. So in this paper, which I'm going to send out to all of you, Axert, which is amitriptan, Zomig, which is zolmitriptan, have been studied. And then sumatriptan has also had some evidence, which is Imitrex. But those are the main main therapies that have been studied so far, in particular in vestibular migraine or migrainous vertigo, and have shown some evidence. And we typically just use migraine treatments, rescue treatments, just like for vestibular migraine, like we would for regular migraine without vestibular symptoms. Are you seeing that continued use of Gepants improves chronic migraine? Any data on this as a preventative? Yes, actually. I've had a number of patients tell me that the Gepants, meaning Ubrelvy and Nurtec, are, they wish that they could take it every day because it always works, and they only get so many per month. But what I tell them is that that's great news because they're being studied. Both companies, Allergan, which makes Ubrelvy, and Biohaven, which makes Nurtec, are studying these as a preventative treatment as well, meaning that you would take it every day. And that's good on two fronts. One, in that these probably don't cause medication overuse or rebound headaches, which is nice. And then the second is that, you know, if they work as a rescue treatment for you every time, they might work as a preventative treatment too. So we're excited about that. They're probably a couple of years away, a year or two away from being approved for prophylaxis, but it's definitely very promising for the future. And the data so far looks pretty good, although they won't share it with me. But I've just been told that the data looks good so far, but they won't share the actual data with me for confidentiality reasons. But they are in phase 2 and phase 3 trials right now. All right, that's it for the questions I got from all of you. Let me check in the chat box here. Okay. Reyvow, does that make you dizzy? Yes, it does. It can.
Yeah, I had a couple of those.
How do you know which ear to pierce, or do you pierce both? There's not any data on daith piercings, but most people pick the side that they have the most headaches on, and then some people get both sides pierced. Do you think that the new preventatives are more effective than standard oral preventatives like topiramate and propranolol? Topiramate's pretty good. It just has a lot of side effects, and even the longer acting topiramate, which I pretty much give everybody the longer acting one now, or there's 2 of them, but unless they have, you know, Medicaid or something, and they won't pay for the longer acting one. But topiramate can have a lot of side effects, namely numbness, tingling in your fingers, and cognitive side effects. It's not great for women who want to get pregnant or who are thinking about pregnancy. Propranolol, I rarely use because it can cause, in my experience, can cause a lot of fatigue and even some depressed mood. I usually use some of the other beta blockers like Nadolol and Metoprolol. But again, a lot of the oral medications can have side effects. So I'm not sure the new preventatives are any more effective than them, but they certainly tend to have less side effects and be better tolerated. Do most headache doctors have a solid understanding of vestibular migraines? I think so. I mean, like I said, vestibular migraine is often treated very similarly to regular migraine. I wonder if, you know, a lot of just general neurologists have a good understanding of how much the cervical component, how much of a cervical component there is to a lot of people's migraines and headaches and their dizziness. You know, I think that that's something that's underlooked at by a lot of even other neurologists, and certainly by PCPs and things when it comes to migraine. The temptation, I think, is to just kind of try new medicines each time, and people don't look enough at the other factors in migraine. So environmental triggers, medication overuse, mood is way underlooked at. People don't ask about sleep. They don't ask about, and they don't examine their neck and see, you know, I have a ton of patients who come to see me, you know, doctor, I have migraines all the time. Well, their neck won't move. It's like almost like a rigid, you know, they have headaches coming from the back of their head. They're very tender to touch back there. Their neck is very rigid or barely moves. They've never had physical therapy or any kind of treatment back there. Of course they're going to have headaches all the time. I mean, it's just, there's no way that they're not going to have headaches. I'd be surprised if they didn't. So, you know, I think the benefit that you get by going to a headache specialist is they look at some of the other things rather than just trying medication with you. We do use medication, especially if you're interested in it, but we try to look at the whole picture when we see you. And I usually can get a sense of those kinds of things just even on the first visit. What are your thoughts on Botox for migraine? It works really well. Botox, I tell my patients, it's approved for chronic migraine, not episodic, which means that you have to have a headache more than half the month. But in my patients, I've probably found, I estimate about 80% of my patients have some sort of benefit from it. Now, that doesn't mean that 80% of them have zero headaches, but that means that 80% at least get some sort of benefit from it. And most of my patients are happy to get any benefit. And I have had some patients where it gets rid of their headaches entirely. I've had some patients where it helps only a little bit, but they're still happy with it. A wide range of results, but it's very effective. And again, that Botox, I tell patients, is probably the safest medication I give, which is funny because it's a neurotoxin, but you know, it doesn't have any long-term side effects. We've been using it for decades for various conditions. It's limited to your head and neck, so it doesn't travel throughout your body, doesn't get into your bloodstream. It's, you know, I have talked with my OB colleagues about this, and I routinely use it in pregnant women because, again, it just doesn't make an anatomical sense why it would affect a baby. And also there's been some retrospective data on safety in pregnancy with it. So Botox is a great treatment. It's, you know, I use it. Some people really don't like needles, and that's fine. And I use it pretty interchangeably with the new CGRP antibodies. Do you find a lot of patients with multiple migraines? I've been diagnosed with 3 types of migraine, all coinciding, and find it very difficult to find relief. It's probably, you know, the condition, that's a thing that's kind of a push in our field, is to call the condition migraine, that you have migraine. Like you have migraine, not you have migraines. And I know it's kind of a semantics thing, but migraine is, you know, a condition with a wide variety of different symptoms. And you have that condition, and some of the headaches that you get or the symptoms that you get with it are probably different. But you don't have 3 different types of migraine. You just have migraine. And then you have migraine with a few different types of symptoms. How many days of a persistent migraine should a patient call you for the next level intervention? For example, if it's been 5 days of trying everything, should they call their doc? You typically want to know sooner or later. I typically say 2 or 3 days. You know, typically the triptans, rescue meds don't work very well after a couple days into the headache. There are things we can do. We usually do oral steroids or muscle relaxers, or we even have an IV. You know, here at OSU, we have an IV treatment center that they can come in and get an IV treatment. We have our nurse at our office will give, you know, a Toradol shot or a Phenergan shot. So we have a few different options if you have a migraine going on for several days. So I tell patients to let me know if they are having one that won't break after 2 to 3 days. And then, you know, and I've been as guilty of this as anybody. You know, in the past, I tend to just give them some treatment for it and not think about the fact of why are they having a migraine lasting that long? Like maybe their rescue treatment isn't good, or maybe they're not taking it on time. So I've made more of a push lately to really kind of address that when they call in with a migraine that's lasting that long. Because, you know, if you're having migraine, you know, everyone every once in a while has a bad cycle, or a lot of migraine patients do, where they just, you know, have a migraine every day for a couple days. But if it's something that's routinely happening, then maybe we need to switch your rescue treatment or figure out what the problem is. Maybe you're not taking it soon enough. You know, I had a couple weeks ago, or maybe it was last week, I can't remember. I had one, I think, every day for 3 or 4 days, which is very weird for me, but it was when the weather was changing, and that's a very common trigger for a lot of patients, especially here in Ohio, where we have wide varieties of weather. I would think Colorado would also have a problem. I saw that about a month ago they had one day where it was like 90 degrees during the day, and then it dropped to 30 at night, and there was snow. We don't have anything quite that drastic here in Ohio, but we have some days in October where it goes from 70 down to 50 the next day, and then we have in February, March, we'll have some days that are 60 degrees followed by some that are 20s. So weather variety is a huge trigger for bad cycles for my patients, and that's typically when I get a lot of calls like this about symptoms going on for a long time. What does one do for the cervical component of migraine? Typically, there's a few things we can do. Physical therapy is one. Sometimes if they have a lot of migraines, we'll do Botox for those patients. There's also some injections, cervical injections like yield branch blocks, RFAs. In my office, I don't do any of the real invasive procedures, but I have some colleagues who do. And then I do like occipital nerve blocks. Those are things we can do, just peripheral blocks for the cervical component. There's also some of the medications are better, like for those types of headaches, like the tricyclic antidepressants, like amitriptyline are probably better for those patients. So there's patients who have a huge cervical component of their symptoms. We treat a little bit differently than the other migraine patients. So I think that's it for the questions I have. Does anybody else have any other ones?
I think that's it. Unless there's any other questions real quick. We really appreciate your time, Dr. Weber. That was a fantastic presentation, and thank you so much for answering all of the questions that came in and that came up in the chat. Very informative, and we just really appreciate your time and just some thank yous. So thank you again. I know you're probably a little bit sleep deprived, having just had a couple of babies come home, right?
Yeah, they're doing okay though. They are. I can't complain. They're blessings, and they definitely change your life. That's for sure.
Yeah, they make everything really worth it. So, well, thank you so much for your time, and we really appreciate everything. And I hope everybody has a great day. And thank you all for attending.
I will send. I'll send you guys my PowerPoint that I gave to our. My PowerPoint that I gave to our ran rounds earlier this year, that had some of the slides that I used today, and then I'll also send that vestibular migraine article.
Oh, that'd be great.
Hopefully, for those of you who don't live in the Ohio area, you can use those websites, the American Migraine Foundation or the UCNS website, to find a headache doctor near you. There's a few of us. There's definitely not, and some states have more than others, but and it can be challenging to get into one, but you might as well get your name on the list now. Maybe an opening will come up, and you might as well talk to your doctor about getting a referral sooner rather than later.
Absolutely, agree with that completely. And we'll put those links in our group as well, so people can access those quickly. So
great.
Thank you so much. Have a great day. Enjoy this weather, because it's actually nice.
I will. I'm going to. Thank you.
All right, enjoy. Thank you all.
Bye.
Bye-bye.